Let us continue with meningitis. Today we are going to discuss about the clinical presentation and diagnosis. So once the patient is brought to the hospital, we have to diagnose the patient. For that we have to assess the signs and symptoms of patient, right? For that we have to study in detail the clinical presentation and diagnosis of meningitis. First of all, let us take a look at clinical presentation and diagnosis in general. So what is its pattern? As we discussed before, etiology varies with age. Similarly, clinical presentation also varies with age. And generally, the younger the patient, the clinical presentation can be more atypical and less pronounced. That is, it can be more unusual and less noticeable. For example, in neonates, signs of meningeal irritation may be absent, whereas in elderly patients, many of the classic signs of meningeal irritation are absent. Up to 50% of patients may receive antibiotics before a diagnosis of meningitis is made. So this delays the clinical presentation of the patient in the hospital. Prior antibiotic therapy may cause the gram stain and the CSF culture to be negative, but the antibiotic therapy rarely affects the CSF protein or glucose. Now coming to the signs and symptoms of the meningitis. There is a characteristic triad for acute bacterial meningitis which includes the most common symptoms. That can be fever, nuchal rigidity, change in mental status. So nuchal rigidity is nothing but the stiffness of the neck, and change in mental status means that can be conditions such as confusion, lethargy, that is tiredness, and sometimes coma. So in this figure you can see normally we can flex the neck to forward or backward. So in nuchal rigidity you can see the inability to flex the neck due to rigidity of the neck muscle. Now coming to the other classic signs and symptoms, they can be fever, chills, vomiting, photophobia. Photophobia means light sensitivity, that is eye discomfort caused by the light, severe headache, and nuchal rigidity associated with Kernicks and Brudzinski's sign. So Kernicks and Brudzinski's signs are nothing but the signs which helps to examine the patient to derive a diagnosis of meningitis. So in this figure you can see photophobia. Now coming to the Kernicks sign. So this is named after a Russian neurologist Waldemar Kernik. For this physical examination, initially the physician makes the patient to lie in the supine position. So supine position means lying on the back with the face upwards. So first of all you can see two figures A and B. In the A figure, first of all the examiner raises the knees of the patient to form a 90-degree angle. So you can see here 90-degree angle, and then the examiner attempts to extend the knees. So here you can see the arrow which indicates that the examiner attempts to extend the knees. In the second figure B, you can see once the knee angles reaches the 135-degree angle, a contracture or extensor spasm occurs. That means you can see a painful extension or contracture or resistance of the patient, which indicates a positive sign. So this is the Kernicks sign. Then coming to the Brudzinski's signs. So there are two types, Brudzinski's neck signs and leg signs. So first of all let us discuss about Brudzinski's neck signs. So in this there are two figures A and B. So in the A figure, the patient is laid down in the supine position and the physician tries to extend the neck, that is flexion of the neck. So in the second figure you can see, as the result of the flexion of the neck, the hip and knee flexion occurs. You can see the pain or resistance, then it indicates the positive Brudzinski's neck sign. Now coming to the Brudzinski's leg signs, in this you can see three figures C, D and E. In the C figure, the patient legs is flexed by the examiner. So you can see the arrow. So it indicates the flexion of the leg. At the time of the flexion, the contralateral leg begins to flex. So this this arrow indicates the identical contralateral signs of the patient. The contralateral leg now begins to extend spontaneously, resembling a little kick in the third figure. So here you can see the arrows which indicates the little kick. So it indicates the positive Brudzinski's leg signs. Other signs and symptoms include irritability, delirium, drowsiness, lethargy, and coma. Irritability means a state of being irritable, and delirium means altered consciousness. Lethargy means a feel of tiredness, lack of energy. In addition to these all signs and symptoms, in young children we can see clinical signs and symptoms such as bulging fontanelle, apneas, purpuric rash and convulsions. So bulging fontanelles are nothing but bulging of the fontanelle. So this fontanelle is an anatomical feature of the infant human skull, which comprises any of the membranous gaps between the cranial bones of an infant. So normally when we are touching, this fontanelle should feel firm and very slightly curved inwards. So in the meningitis patients, we can see the bulging of this fontanelle. So you can see this structure here. So bulging of the fontanelle can occur when the fluid buildups in the brain or the brain cells, causing increased pressure inside the skull. So this results in the bulging of the fontanelle. Coming to the seizures, which is another sign and symptom. So seizures occur more commonly in children, that is 20 to 30%, than in adults. In adults it occurs at a rate of 0 to 12%. So the seizure which occurs can be focal or generalized. Now coming to the differential signs and symptoms, that is the similar signs and symptoms. You can see purpuric and petechial skin lesions typically when the infection is caused by the meningococcal. Meningococcal means infection with the Neisseria meningitis, and these skin lesions are also present with Haemophilus influenza infections, and these rashes are rarely occur with the pneumococcal meningitis. So let us see what are purpuric and petechial rashes. So in this figure you can see the spots. This is petechial lesions, and these are formed when tiny blood vessels, that is capillaries, are broken and the blood leaks into the skin. So these spots are flat and they look like pinpointed red, brown or purple dots. In this figure, you can see the clumps of the petechial rashes. That is, when the petechial rashes are in group, they appear as a big rash in the skin, which is called as purpura. So in this figure, you can see both petechial rashes and purpura together. Now coming to the another differential signs and symptoms, Waterhouse-Friderichsen syndrome. So it is the adrenal gland failure due to the bleeding into the adrenal gland. There you can see a rapid eruption of multiple hemorrhagic lesions associated with a shock-like state. So this is caused by the etiologic agent meningococcus, that is Neisseria meningitidis. So in Waterhouse-Friderichsen syndrome, you can see the bleeding of the adrenal gland like this. And during the meningeal infection, certain pathogens such as Haemophilus influenza and meningococcus, they can cause the involvement of the joints. And in case of the pneumococcus infections, the history of head trauma with or without skull fracture or the presence of chronically draining ear, they can be associated with the pneumococcal infection. Now, coming to the laboratory test. So, we have to perform the laboratory test to diagnose the patient and to specifically identify the etiologic agent, right? So, we have to perform the analyzing of the CSF by conducting a lumbar puncture. So this performing a lumbar puncture to examine the CSF is a crucial step for establishing the diagnosis. So several tubes of CSF are collected via lumbar puncture for the chemistry, microbiology and hematology tests, because theoretically the first tube which has the higher likelihood of being contaminated with both blood and bacteria during the puncture. So several tubes of CSF cerebrospinal fluid is collected. So CSF should not be refrigerated or kept on ice. Okay. So when we are conducting the analysis of CSF, typically we are measuring the glucose and the total protein content. So an elevated CSF protein of 100 mg per dl or greater and a CSF glucose concentration of less than 50% indicates that bacterial meningitis is present. This chart elucidates the CSF glucose, protein, WBC count in normal as well as bacterial, viral, fungal and tuberculosis infections. So, the values for CSF glucose, protein and WBC concentration found with bacterial meningitis overlap sometimes with those for viral, TB and fungal meningitis. Therefore, CSF WBC counts and CSF glucose and protein concentrations cannot always distinguish the different etiologies of meningitis. Now coming to the other diagnostic testings, we have to conduct other diagnostic testings to ensure that the patient is having bacterial infection. So other tests are blood culturing and culturing of other specimens. Okay, so this blood culturing can be CBC, that is complete blood count, and other culturing include complete metabolic profile, prothrombin time, partial thromboplastin time, urinalysis and all. So when we are conducting the CBC or the culturing of the bacteria or the culture and sensitivity test, we have to take a minimum of 20 ml of blood in each of 2 to 3 separate cultures per each 24-hour period. This is necessary for the detection of the bacteria. Next one is the gram stain and the culture of CSF. So this gram staining is the most rapid and accurate method for diagnosing the bacterial meningitis. So if you are conducting gram staining prior to the antibiotic therapy, this is the more sensitive and rapid test for 75 to 90% of the cases. And we have to do the culturing. This is required for the differentiation of the causative organism. And we can use PCR techniques, that is polymerase chain reactions. So this helps to diagnose the meningitis caused by organisms such as Neisseria meningitidis, Streptococcus pneumoniae and Hib. So this is highly sensitive method, but this method is limited. The use of this method is limited because of the expenditure. Now another method is the latex fixation, latex coagglutination and enzyme immunoassay. These tests provide for the rapid identification of several bacterial causes of meningitis including Streptococcus pneumoniae, Neisseria meningitidis and Hib. Now coming to the diagnosis of the tuberculosis meningitis, we can conduct acid-fast staining, culture and PCR of the CSF. For most of the viral meningitis infections, we can conduct PCR testing as the CSF. So this is the preferred method for the diagnosis of most viral meningitis infections. And fungal meningitis can be diagnosed with the help of culture, direct microscopic examination of stained and unstained specimens of CSF, antigen detection of a cryptococcal or histoplasmal antigens, and antibody assay of serum and or CSF.